all hormones right now because it could be causing breast cancer. And the proper story wasn't communicated truthfully. So I just want to go over briefly what the study was about. The primary goal was to see whether estrogen could decrease the risk of cardiovascular disease in women. And they also did whether they wanted to do a safety study and assess whether breast cancer risk or there was any other long-term safety issues with hormone therapy. So there were two arms. There was the Premarin arm and the Prempro arm. The Premarin arm was the estrogen arm. Now, they were using pregnant mare urine or pregnant horse urine, which is not bioidentical, completely synthetic, harder for our bodies to recognize and metabolize. But actually it showed a lot of benefit despite it being pregnant horse urine estrogen. And they were taking it orally. We never give estrogen orally because it can lead to a slight increase in clotting, just a slight increase. That's why women who take birth control are told not to smoke because of that the oral estrogen. And then the second arm was the Prem-Pro arm, so the Premarin plus progestin, which is a synthetic progesterone. And it's also known as medroxyprogesterone acetate, which is super, super inflammatory, as I'll show you. So they stopped the study, but they kept the Premarin group going, the estrogen-only group. So they continued that. They stopped the Prempro group. And they were finding that estrogen was having protective benefits. And then in 2020, when everyone started talking about hormones, they realized that the estrogen-only therapy actually protected against breast cancer and death. Yeah. So estrogen, the Premarin group, had significant protective events in lowering rates of Alzheimer's, reducing colon cancer risk, and improving cardiovascular outcomes. And most importantly, it protected against breast cancer. And this, again, this is synthetic estrogen, right? So what was the problem? It was progestin. It was the synthetic progestin combined with the estrogen that was responsible for the negative effects like breast tissue proliferation, abnormal breast tissue proliferation, ovarian stimulation, bloating, weight gain, and estrogen was not the culprit. Okay, so how I can help. So why see someone like me who's a naturopathic doctor? There's a ton of MDs, DOs, nurse practitioners that are getting trained in functional medicine right now, and they're talking about hormones. But I just want to show you, I get a lot of patients coming in, and I just want to kind of summarize what you'll get if you see your primary care and then your OB-GYN. And this is what I hear a lot of my patients telling me. So they go to their primary, they're saying, I can't sleep, I'm fatigued, I'm gaining weight, I'm moody as heck, and oh, but the PCP says, are you still on your period? Oh yeah, I'm on my period. Then you don't need to be on hormones, you know? So, what?
My OB.
Yeah, and that's the problem. So, but then they'll punt and go, okay, why don't you see your OB-GYN? And if you get a good OB-GYN, they might put you on a patch and progesterone, but usually the progesterone is every single day, and you don't want to take progesterone every single day because it will block estrogen's effects. Remember I said estrogen was the queen, and that needs to be the queen hormone. Progesterone should only be cycled in. But I don't want to get into the details there, but taking them together every day does block estrogen's effects. So, you know, if you go to your OB-GYN, you usually have a short visit. They're focusing on symptom management. They might run an estradiol on you and maybe a progesterone, but they don't know when to time the labs, and so they'll time it, and your estrogen's maybe 150, and they're like, oh, great, you're good, you don't need hormones, but they're not checking FSH and LH, which are the brain hormones that are telling your ovaries, I need more estrogen, I need more estrogen. And remember I said some months you can make a lot of estrogen, and some months you won't, so it depends on when you're testing. And also in perimenopause, I have to say that some months you overshoot a normal estrogen, so your estrogen can get pretty high for some months. So, so labs, they come back normal, and they'll go, come back in a year. Let me know. And in the meantime, for a year, you're suffering. You know, you're just fatigued and you don't feel well. And so I think that's a disservice. If you're lucky, you might get a patch. You might get a low dose patch. And again, progesterone every day, but yes, you'll feel better, but you might not be optimized. You might not feel your potential, what you could feel. Because you could feel a lot better if you cycle your progesterone and you go up to an optimal dose of estrogen, not the lowest dose, optimal dose.
How do you determine the optimal dose?
Usually you want your estradiol between 60 to 120. And so, you know, I have a lot of patients who are at 20 or 30, and you're just not going to get the bone, the brain, and the cardiovascular risk protection. Yeah. So usually about 60 to 100 you're wanting, and it gets a little tricky. I don't want to get into the nitty gritty, but there's so much nuance with hormones. So you really have to track that first year, that when you start on hormones, tracking every 3 months with labs in hand. And again, I do like to start my patients on hormones while they're in perimenopause, while they're still cycling, because bone loss starts to happen then. Blood pressure and cholesterol start to rise. You're getting longevity protection when you start in peri. But again, it's such a fluctuating time, so we do have to check in at least twice a year in peri. So, you know, as a naturopath, as a functional doctor, we look at all your organ systems. I'm not just looking at your genitourinary health. I'm looking at your brain. I'm looking at your gut. I'm looking at your heart. I'm looking at your lymphatics, your thyroid, everything, because everything is connected. I do a super detailed lab. I mean, I do a very detailed lab, and I'll go into what that entails in a little bit. I get a lot of extra training. You have to, because everybody is different. Every single one of you women are so different. You will be on different protocols. Well, not that wildly different, but you know, some might have to be. And we talk about lifestyle, and I love herbs, and there's supplements, and there's homeopathy sometimes, and so,
Dr. Han, can
Yeah.
I ask a question? And sorry, I know we're going to wait till the end too, but I had heard too that many doctors did not get any menopausal education, and so we're going to our OBs thinking that they have, you know, this training, but a lot of them, from what I understand, don't.
They don't.
And so they have to go seek out more specialized certifications.
Exactly.
So that's why it's hard, because you think your OB, they delivered your babies, they're like, they should know this stuff. So it's so disheartening to think that that's where you would think that you go, but they don't have that training.
Unfortunately not. They have to get additional training. And honestly, in naturopathic school, I didn't get much hormone training either. So I got it all doing these trainings and working with another naturopath who does a lot of hormone therapy as well. I needed to see and immerse myself in seeing a lot of patients and getting this training on my own. Yeah, unfortunately, even as naturopaths. And we were taught to dose by us, which, as you know, is only 80% estradiol and 20% estradiol. It's low dose. And yes, women may feel better, but they're not gonna feel their best, and they're not really gonna protect their bones and their brain as best as they could. So common labs I order prior to starting bioidentical hormone replacement therapy is those brain hormones, right? The pituitary hormones telling your ovaries I need more estrogen and progesterone. So FSH, LH, estradiol, estrogen, progesterone, total and free testosterone, dihydrotestosterone, the adrenal hormones, DHEA, sulfate, cortisol. I do a super detailed lipid panel because a lot of my perimenopausal patients are coming in with their lipid panel looks great. Their total cholesterol, LDL, HDL, but then I look at their LDL particle number and their size and shape, and they're high. So they do have risk of increased cholesterol and eventually cardiovascular disease. So it's super important to run those lipid panels. Insulin, glucose, hemoglobin A1C, full thyroid panel, right? A lot of these doctors are only doing TSH and maybe a free T4, but you've got to run all of those thyroid labs as well. I do tell my patients to get annual mammograms every year and a transvaginal and abdominal ultrasound every 1 to 2 years. And then getting a bone density. Women are told at 65 to get a bone density, but their bones are declining in their mid-40s. So I say by 50 to 55, get a DEXA just for a baseline. And then I usually test on day 12 of your cycle in a perimenopausal woman because that's when estrogen is usually the highest. And I want to know what their highest estradiol level is. So this is a typical case. Deb is a 47-year-old woman with poor sleep, increased irritability, hot flashes, night sweats before a period, wants to discuss hormones. So as you see, this FSH, it's in the double digits, and LH. FSH tells the ovaries to make estrogen, LH tells the ovaries to make progesterone. So they're rising. An MD might look at that estradiol and go, oh, that's fine, but that's not optimal on a day 12. Progesterone and DHEA are, DHEA is on the lower side a little bit, and that's adrenal hormone. Thyroid function is declining a bit. I like that TSH between 2 and 2.5, and I like those hormones higher, the free T3 and free T4. This A1C is pre-diabetic to me. You want to get that hemoglobin A1C under 5.5. And as you see, I don't know if you guys can see back there, but her total cholesterol is rising. That total cholesterol is now 235. Triglycerides are on the lipid panel, but they're not a cholesterol. They're more, they're a fatty acid that can lead to fatty liver, and that's more influenced by by glucose and sugar and carbohydrates, refined carbs. Her HDL looks good, her LDL is climbing, and she's got a lot of inflammation. That CRP should be less than 1. Her vitamin D is low. I like that between 60 to 80. That helps with bones, immune, and brain. Bones, immune, and energy. So for this woman, I just wanted to give you a typical kind of dosing, but because she's perimenopausal, I'm not starting her on the lowest dose of a patch. I'm starting middle dose to higher. So 0.05 to 0.1 patch that you change twice a week. And then again, you would take progesterone just 2 weeks out of the month from luteal phase until you bleed. And that's before bed. Now, I only recommend oral progesterone if you have trouble sleeping and if you have anxiety. Otherwise, if you don't, then I'm gonna, as I learned, I was just in Mexico. I was at a hormone conference with one of my favorite, Jenny knows her, Dr. Felice Gersh. She's a medical doctor, OB-GYN. She's amazing. She's an 80-year-old woman. She's been on hormones probably for 40 years.
And the best skin.
The best skin. Her hands and her face look so young, and she is dynamite. I mean, her brain is so sharp, and she is such a great educator. But she does not like to give everyday progesterone. She likes to cycle it, and that's how we do it when we're cycling. We do not make hardly any progesterone from the time we bleed until we ovulate. Progesterone just comes on board from ovulation till we bleed. So we're mimicking a natural cycle. So if you don't have sleep issues, then I would recommend progesterone vaginally or rectally. I know it sounds so odd, but sometimes you can't do it vaginally because progesterone increases the pH of our vaginal environment, and if you are prone to yeast infections, you can be more prone to yeast infections. So you want that vaginal pH to be very acidic to kill off any bugs or yeast that might be wanting to colonize there. We did lifestyle, and then I followed up with a 6-week visit just to check in on her symptoms, and then we do labs every 12 weeks for the first year. And then we usually do twice a year after that with labs. Yeah.
So for someone that is in full menopause, like right now I'm doing a daily progesterone, but do they even do like a topical version of it? They do a testosterone or no?
Yes, I'm sorry, you can do progesterone topically as well.
And you would say, like for someone that is fully in menopause and you don't know what you're not bleeding,
right?
Do you still have to do it like every 3 weeks? Or?
Yeah, great question. So then you would just pick like the 1st to the 14th or the 14th to the 28th of every month. Okay. Yeah. The reason why, this is getting into the getting pretty detailed, but yeah.
I can just schedule it.
But The reason why, it's because that progesterone holds that lining, right?
Mhm.
So you don't have any bleeding issues when you take progesterone daily. When OB-GYNs see blood in a 55 or 60-year-old woman, they're like, uterine cancer, endometrial cancer. So that's why progesterone is given daily. But is it the best as far as what estrogen's doing? Not quite. So that's a visit, and I'll yeah, that that's why it gets a little tricky. And so actually just some women, we might want to create a bleed every 3 months. I know it sounds so odd, but you want to create that bleed so you're letting go of that lining, so that lining doesn't get too thick. Because if that lining gets above 10 millimeters, you do have a chance for atypical cells, and then worst case scenario is endometrial cancer or uterine cancer, right? So you do want to let go of that lining every a couple months.
I think Dr. Gersh says, if you build it, you must shed it.
Yes, Dr. Gersh
Yeah,
is exactly.
Yeah.
And actually, yes. Anyways, okay, so this is a menopausal case study. So this woman, 51-year-old Kathy, 8 months of miserable hot flashes, irritability, low energy, no libido. She hasn't had a period for 14 months. Her pap and mammogram is normal. Decreased sexual activity due to vaginal dryness. She does have hypertension and high cholesterol. She's on a blood pressure medication. Non-smoker, alcohol 2 to 3 glasses a week. Her BMI is great, 24, under 25 is what I aim for. Blood pressure, a little bit of a higher systolic at 128. I like it under 120/70. And she's exercising. Good diet, cooks most meals, new to San Diego, no PCP yet. So her workup, we did these labs. Look at that FSH. Anything above 25 does mean that you are in menopause. Yeah, your ovaries are done. Her estrogen, her sex hormones are really low. Her total testosterone is really low. My goal is 20 to 40, and then free testosterone is low as well, and I like free testosterone between 1 and 4. So for her, we did a patch or transdermal. Again, progesterone, oral, vaginal, rectal, or transdermal is an option as well. And I did do topical estriol because of that dryness. And estradiol can go systemic and can help with vaginal dryness, but it can take a while. It can take months. And so topical estriol is pretty immediate. I mean, within a week or two, you feel much more comfortable. And testosterone, we add when estradiol and progesterone levels are optimized. Usually takes about 6 months to a year. Okay, this is my last pretty big case. So I wanted to bring this case up because hormones can get complicated. And just because you start on hormones doesn't mean it's like, okay, then life is gonna be good, right? And so Nikki was a 63-year-old female. I just saw her last week. She's been on a very niche type of protocol. It's called physiologic hormone restoration therapy. It was created by a woman called T.S. Wiley in the early 2000s. It's where you mimic a 30-year-old woman's cycle. So you're bringing up her estradiol and creating an LH surge to ovulate, and you're pretty much mimicking a 30-year-old woman's cycle. So these women are bleeding every month, even if you're 60, 65. Again, very niche, not very common, but she's been on PHRT since she's been 50. She had a partial hysterectomy at 48 years old. She had fibroids and endometriosis and menorrhagia, because fibroids and endometriosis can cause heavy bleeding, especially in perimenopause. She did take out one of her ovaries. She went on PHRT, or physiologic hormone restoration, and she felt amazing. So I see women, they come in, they're tired, they're not sleeping, they're just so tired. And then we start on hormones and it's like literally a new woman. I mean, she's happy, there's a light in her eyes, her skin's, there's more color to her skin. It's like it's the estrogen look. So she felt amazing. But her cholesterol was still high, and I'm like, when you get on hormones, your cholesterol starts to drop. And she had moderate family history. Her mom had a TIA stroke at 77. Her dad had lung cancer related to asbestos and passed away at 51. But I imagine if he lived until 55, 60, like he would have high cholesterol because her paternal aunt had high cholesterol. I ordered a coronary artery calcium score. It's like a CT score. It measures how much hard plaque is in your arteries, in your coronary arteries. And anything above 300 is high risk for a cardiovascular event. So we ran it, it was 346. So a CAC measures only hard plaque. You can't see soft plaque in there. There could be soft plaque forming and turning into hard plaque. So we really had to do a CT angiogram. But she brought this to her PCP and the PCP's like, don't worry about it, it's fine. But she pushed for it, so glad she did. She got a CT angiogram, her score was high at 340. There was a 30 to 50% occlusion in the left descending artery of her heart, which is called a widowmaker. So she could have had a heart attack, So I think knowledge is power, and I think, so now she knew that she had to do something to try to be a little bit more aggressive about bringing down her cholesterol. Her weight was also bugging her, and she was having a real hard time losing weight. So she was a yoga teacher, super aware, super in line with her body, but she was eating a high protein, clean diet. She was scared of carbs like oatmeal, and she wasn't losing weight. So then she decided to change her diet and to decrease her saturated protein, her beef intake, and switch to increasing her fiber and adding more lean chicken, so chicken breast versus chicken thighs, and more beans as protein, and more fish and less red meat. And then finally she started to see the changes. Her LDL went from 129 to 45 in like 3 months, or 5 months. Her total cholesterol went from 195 to 116. Her ApoB, that's a cholesterol marker, went down to 55. And then her weight and her blood pressure started coming down. So I brought this case up for one of the reasons was we're all pushing high protein, because we're losing muscle. But one diet doesn't fit all. And I'm sure Jenny has seen this, like, you can't just fit one diet and think everyone will do well on it. For her, she needed lean protein and more fiber. And I think with this high protein diet, we forget about vegetables. And it's so important for colon health.
Half your plate, people, half your plate.
Half your plate, exactly. 50% of your meal should be vegetables. So, with her, she was on a statin. Yeah, she was on 10 milligrams, super tiny dose, and ezetimibe, which is a non-statin cholesterol lowering drug. It inhibits the cholesterol binding in the small intestine. Small dose. And then she was on red yeast rice, CoQ10, fish oil. I'm okay with that. And she's seeing a cardiologist. But I imagine if she wasn't on hormones, she'd have to be on a higher dose of statins. And that can cause a lot of fatigue and just not feeling well. So key takeaways. She didn't need a high protein diet. She just needed more fiber and less saturated fat. Her blood pressure went down. Her weight started to melt off. She's meditating more because she's Portuguese, and she says that they're very passionate and emotional, and she sees that calming down her nervous system is so important as well. She's doing a mindfulness-based stress reduction retreat in December of 2025 in Encinitas to address her nervous system. Her cardiologist, who's a young male, wanted her to go on the lowest dose of estrogen because he still thinks that transdermal estrogen can cause clotting, and it doesn't. They are going to change their boxes finally on the transdermal estrogen patches. And it's complicated. It's not straightforward. She's been on hormones for 13 years. I mean, our bodies are always changing, and sometimes we need to pivot, right? We need to pivot sometimes. She feels good now. She's all right. So, I mean, I went over these. These are the common dosing strategies: the patch, cream, progesterone, right? Testosterone is 1 to 2 milligrams once or twice a day, and then labs. Estriol, we talked about, great for vaginal integrity. One short little case, I saw Ronnie 75-year-old female. She was having so many UTIs, antibiotics every month, but she also had rheumatoid arthritis and metabolic syndrome, which is diabetes, high cholesterol, weight gain. And I got her on vaginal estriol within a few weeks. No more UTIs, no more having to go on antibiotics to destroy your gut, the gut microbiome, and cause more inflammation and more distress. I brought these books back there. These are great books just because they give you a research-based science article research-backed information about all the hormones and the benefits. So there's Estrogen Matters, Stay Young and Sexy with Dr. Jonathan Wright, who's in Washington. And Sex, Lies, and Menopause is by T.S. Wiley. So she is the woman that thought up the physiologic hormone restoration therapy. So if you're interested, very interesting approach. Not for everyone. So just some considerations before considering hormones is that there is a risk benefit. There's a ton of benefit, but there's also some risk. For example, if you have breast cancer or you come from a strong family history of breast cancer, you have to be super careful with these hormones. Any kind of reproductive cancer, right? Ovarian cancer, uterine cancer, endometrial cancer, estrogen. Now, I don't believe, and many of my colleagues and teachers don't believe that estrogen causes breast cancer or reproductive cancer, but if you do have a tumor, I said that estrogen is a growth factor. If you do have a tumor, even though the estrogen didn't cause the cancer, it could make the cancer grow. It could make it grow. So, and you have to be super careful with women who have fibroids, ovarian cysts, and endometriosis, because that estrogen can aggravate it as well. And one more thing about hormones is that it was always thought shortest dose for the shortest amount of time, which is about 5 to 10 years, and then you stop. Once you're 65, you stop. But it's changing because once you stop the hormones, you get benefit for about 1 to 2 years, and then your bone loss starts. The dementia can start coming in, and then the lipids will go up. So it is for life. I mean, if you do want this protection for longevity, it is for life. Key takeaways, remember lifestyle and foundations are first. Food is medicine. Gut health is so important. Dr. Bester, the school that I went to, he did believe that disease starts in the gut, so we have to start there. Not necessary to be afraid of hormones, it can help. And yeah, any questions?
That was so good.